Thank you, Alistair, and good evening, everyone. I mean, one of the things to note is that during the peak of COVID, there was approximately a 30% reduction in systemic treatments. And remember, here we're not just talking about chemotherapy, we're talking about immunotherapy, the new targeted drugs. And actually, a lot of those, that reduction was related to the so-called treatment pauses that were introduced. I think to mitigate against the risk of COVID-19 in patients receiving potentially immunosuppressive treatment. And in fact, according to the CRUK figures, there have been 6,000 patients fewer treated with chemotherapy during that time, which is not entirely unexpected. And I think that in general, the oncologists and the patients made the right decisions and were able to maintain treatment as best as they could early on. Of course, it's a very much a dynamic situation where, you know, there's not a day goes by then we don't learn more about the virus and how it interacts with patients and patients receiving chemotherapy. You know, for example, the latest publication from the UK Cancer Coronavirus Project, interestingly, did not find an excess mortality in patients who had been treated with chemotherapy within the last 4 weeks compared to those who just had a cancer diagnosis. So although we talk about the risks of systemic treatment, we still haven't got a complete handle on that. The other interesting point is that we've not yet recovered to the levels of pre-COVID, and that's a complex matrix. But at least one of the reasons is because, as you've heard, that there is a significant number of patients not being diagnosed, and these will come through. And so it is absolutely vital that we maintain capacity. And maintaining capacity within the current environment of social distancing is important. And there are simple innovations that can take place: wearing masks, having curtains, having screens. All of these things mean that you can maintain capacity within your chemotherapy unit. But one of the key things, I think, is safety and confidence. And we need to have the safety and confidence of our patients, because as a practicing clinician, there's some patients who said, look, I really don't want to have treatment, even if it is going to help, because I'm scared I'm going to die of COVID. And so we need to introduce regular testing of staff and of patients, both pre-symptomatic, asymptomatic. I know Carol will probably say something about that later. But I think that's certainly a key point. Let's create a safe environment. Let's produce confidence in patients. Let's build on capacity and let's deliver. Lots of innovations have gone on. Some of them you've heard from Peter already, you know, using oral drugs rather than IV drugs, looking at schedules and schemas of administration, using apps to get toxicity reporting. So there are many ways in which I think, and again, to talk to Alistair's point, these are here to stay, hopefully. A lot of the things that we've developed under the auspices of this crisis will have improved practice and have improved efficiency of care. And I think that's a key thing moving forward. So I think there's much hope. I think that we're gearing up to respond to the need that's just around the corner, and hopefully we can continue to enhance the efficient delivery of cancer care. Thank you.